Hello, I'm Dr. Tim Noble and I'm the Medical Director at Doncaster and Bassett Law NHS Trust. At the end of 2019 we were aware of reports coming out of China of a new viral infection which was causing quite significant illness. Obviously we then got information from Italy as the disease spread. So we were preparing for a potential impact on the UK towards the end of 2019 and early 2020, and as things played out, obviously the disease took a hold and spread to the UK, where we had to then really ramp up our measures. We implemented changes very rapidly, and looking back, it's incredible to see what the whole NHS has done to deal with COVID. However, in the Trust, we assessed how much oxygen we would need and how much oxygen we had, and discovered that we perhaps would need more oxygen. So we had to establish a whole new way of delivering oxygen around the Trust. We had to have a monitoring system for how much oxygen was available, and even down to the level of each ward, having enough oxygen per ward was constrained by the pipework, which is a natural limitation. As you recall, in the early days, the tests for COVID had to be sent off to regional laboratories, and the turnaround time was quite long. So we were left unaware of whether a patient was truly infected or not. Over time, the testing capacity for the Trust and for the nation ramped up significantly to the point we're at today, and that really helped. We also had to consider what risks there were to staff and provide personal protective equipment, and nationally and internationally there was a shortage of the required equipment, and so we had to make things as safe as we possibly could within the environments that we work. We had to make a really tough decision early on in the pandemic as to what we would allow in terms of relatives visiting patients in hospital. It was completely counter to what we're used to. We're used to welcoming friends and relatives into the hospital to see their loved ones when they're ill. And unfortunately we had to take the decision, it was a national decision, to restrict visiting for the safety of everybody and to limit the spread of the known cases of COVID. It was very much against what we're used to, but there for a good reason. In the early days, we have no specific experience of treating COVID. We've gathered information from overseas, from the studies that were done in Italy in particular. We looked at whether or not steroids might be beneficial. Our initial thoughts and their initial guidance was they would be harmful and we should avoid them. Obviously, through clinical trials, which were really important, proved that dexamethasone, a commonly used steroid, was beneficial, and other steroids have proven to be so too. The other aspects of therapy were about how we ventilate patients that require ventilation. So non-invasive ventilation with continuous positive airway pressure was initially suggested as unhelpful, although in the first wave we did use it, and in the second wave it was recommended. So I'm really pleased that we were able to be on the front foot with that. The other aspect of ventilation is that in critical care, the teams are used to laying the patient on the front to get good ventilation, a position called proning. This then was used on the wards as well, which was a new venture for the wards, required a certain amount of training, a certain team around to help this to happen, but certainly improved the outcome for patients. Fairly straightforward, but requires a great degree of team working and coordination to help the patient to turn frequently to maintain good oxygenation and relieve pressure areas. So in the initial period, the clinical teams on the ward were learning every day about how to manage the patients with COVID. There was all the new requirements for the personal protective equipment, the special areas for putting the equipment on and for taking it off, and how to launder it safely and not take the virus home with you. All new ways of working for us, and the teams adapted remarkably well to that and very quickly got used to the great inconvenience of wearing PPE. I mean, it's hot and it's uncomfortable, but it's absolutely necessary. Throughout the pandemic, we've received a whole manner of different guidance documents from the Department of Health, from NHS England, and from specialty bodies. And these have helped guide and shape what we're doing. And there are a variety of areas of the condition and its treatment that have changed in terms of the knowledge we've now acquired. So over time, we've learnt that steroids are beneficial. We've learnt that things like hydroxychloroquine are not beneficial. We've learnt that the standard antivirals are not beneficial and are not advised. we've learnt that early antibiotics should be guided by some laboratory tests and not given as a blanket protection. We've learnt that blood clotting is a really important feature of this condition, and prophylaxis by upfront therapy to try and reduce the risk of clotting is absolutely critical, and in probably higher doses than would have normally used. Along with tocilizumab, which is used for the critically ill patient who's got an inflammatory storm, then these therapies have been shown to reduce the length of stay in hospital, reduce time on ventilators, and reduce mortality. The early predictions were of a first wave, which would be a short, sharp peak, followed by a smaller second wave. And we were prepared for that nationally with a period of time during the summer of 2020 when things were relaxed. However, the second wave came much earlier than we anticipated and was much more significant and took a lot longer to reduce, as people will remember. So obviously the really important work was the work on the vaccines, and it was a hugely accelerated program globally. So we have now got a whole suite of vaccines. We've got a huge number of the population of the UK vaccinated, and that's really important to keep working on. And quite rapidly after that program, we saw a rapid reduction in the number of patients admitted to hospital who were in the over 80s age group, a true signal that the vaccine was having an effect. And those that were admitted were less likely to become severely ill. Like many other trusts, we now have a challenge to catch up with the work that just couldn't possibly be done during the pandemic peaks. And we're aware that there are patients who haven't yet sought medical help from anyone. There are patients who have sought medical help and been referred into the trust, and there are patients that we've already seen in the trust and are planning procedures or interventions. And we need to work hard to get through the work that's there for us to do. But we acknowledge that we have to stratify the risks to individual patients and put them in a clinical priority order such that we can treat the sickest and the most important conditions first. In order to do our work, we've had to adapt our environments, and clearly we have to maintain social distance between patients and relatives and staff, and this does alter the capacity of our services and potentially reduces the capacity at a time when we need to increase it. So it is a true challenge for all organisations in the country. The last year has been incredibly challenging for the whole world and our nation and our organisation. We've learnt that the NHS, although often large, slow and cumbersome, can rapidly adapt to some challenges such as this nature, and we have changed so many things, and the staff have been remarkable in their ability to adapt to such difficult environments, trying to deliver the best care possible for the patients that we serve. In the past, we've never had to seriously consider whether patients coughing on the ward could potentially be spreading infection to other people. Throughout this, we've learnt that coughing, having physiotherapy, having certain ventilation techniques, certain procedures are prone to aerosolise viral particles into droplets or fine aerosols. We have never, prior to this, had to consider whether someone coughing on a ward is a problem, whether someone having physio to the back on the ward making them cough is a problem, whether having a gastroscopy is a problem in terms of the potential to spread a virus. You know, people have come in with coughs and colds, we've just carried on because that's what we do. But actually we've learnt now, and it might be different in the future. I think what we've learnt throughout the pandemic will translate into new practices in all manner of aspects of what we do, both in terms of how we consult with patients, how we look after patients who have infections, and how we manage procedures and techniques on the wards. I'd like to thank all people in the organisation for really stepping up to the challenge that COVID has presented to us. We were working closely with our commissioners and our partner organisations throughout the whole of this episode and produced much better outcomes as a consequence of that team working and that collaborative spirit. So we know we'll be living with COVID for some time to come, and whatever the virus does in the future, we have learned a lot of lessons, and the public have shown exactly what they're capable of doing to limit their activities, to limit the spread of the virus in the communities. And I think it's really important that we hold on to some of those features such that we might need them in the future to help protect our population.